Hi, this is Michael Altos, and we are continuing our discussion about the endocrine system, talking about steroids, NSAIDs, and acetaminophen, and this is part 1. Let's start by talking about corticosteroids, or glucocorticoids. These are anti-inflammatory drugs, and they have receptors widely distributed throughout the body. Remember that cortisol is an endogenous substance, and it's a steroid, and your body secretes it about 20 milligrams a day. Secretion is increased in response to stress. Corticosteroids have anti-insulin effects. So when steroid levels increase, we see gluconeogenesis, inhibition of glucose utilization, and hyperglycemia. Steroids have action on vascular smooth muscle, and especially on the response of that muscle to catecholamines, which means to say that when we have the stress hormone present, then catecholamines are more effective and the smooth muscle can contract better. There is also a mineralocorticoid effect, which is basically the action of aldosterone. So we're talking about retaining sodium and excreting potassium. One idea we want to introduce is the idea of HPA suppression. And just jumping ahead for a moment, this is a picture of what we call the HPA axis, the hypothalamus, anterior pituitary, adrenal cortex axis. We see that the hypothalamus secretes corticotropin-releasing hormone, which goes to the pituitary gland, the anterior pituitary, and stimulates it to release ACTH, adrenocorticotropic hormone. And that travels to the adrenal cortex and causes release of cortisol. And then cortisol has negative feedback on the first two glands to prevent further release of cortisol. When we give exogenous glucocorticoids, when we give IV steroids or oral steroids, they also have a negative feedback effect on the HPA axis. And so by suppressing CRH and ACTH secretion, the adrenal gland can start to atrophy. And it may have an impaired ability to secrete cortisol in response to stress or illness or surgery. When patients have HPA suppression, they have risk of cardiovascular collapse, which is basically due to acute adrenal insufficiency during times of stress. And after a patient has been given glucocorticoids, it may take quite some time before their HPA axis has fully recovered back to its normal function. And this depends a lot on the dose and the timing and the duration of the steroid therapy that they had been receiving. Now, technically, you can evaluate the HPA axis. We don't really do this in our preoperative setting, although you may see it done in the ICU. But if you were to do it, you could just check a morning serum cortisol, because cortisol levels change throughout the day. And a morning serum cortisol, if it's greater than 10, it's probably adequate. Less than 5 suggests that it's impaired, whereas in between suggests that you might want to do different testing. For example, you can do an ACTH stimulation test, where you measure their cortisol 30 minutes after giving some ACTH and see how their adrenal gland responds, where a level of greater than 18 suggests that their HPA axis is working pretty well. So how should we approach patients who may or may not need to be evaluated for HPA suppression? Well, we know that if patients are definitely not suppressed, your normal patient who hasn't been exposed to any steroids, there are other patients who have non-suppressed HPA axis. This might include patients who have had less than 5 milligrams a day of prednisone daily for any length of time, or less than 10 milligrams a day of prednisone every other day for any length of time. Anybody who gets steroids for a period of less than 3 weeks is not considered suppressed. And if any of these patients who were treated with steroids in the past year, these are all considered non-suppressed patients, and they can just get their normal daily dosing of steroid, whatever they normally take at home. They don't need any additional stress dose or HPA axis evaluation, and that's it for them. On the other hand, we have patients who are almost certainly suppressed. These are patients on high doses of steroids. So for example, more than 20 milligrams a day of prednisone for more than 3 weeks, or any patient who's taking any steroids if they have clinical signs of Cushing syndrome, which we'll show in a few minutes. And these patients should get stress dose steroids in the perioperative period. And how that's done, we'll discuss in a couple slides. Again, let me emphasize, the purpose of stress dose steroids is to prevent the patient from having cardiovascular collapse due to their inability to mount an adequate stress response. Unfortunately, a lot of our patients fall into the intermediate category, where we don't really know if their HPA axis is suppressed or not. So these are patients who are taking between 5 and 20 milligrams a day of prednisone. Any patient who is suppressed or intermediate who's been treated with steroids in the past year. And usually what we would do is consider an HPA axis evaluation, but that's really not practical in most of our practices. And what a lot of people will do is either they'll just treat them anyway, or they'll wait and see and watch how the patient does with steroids on hand if needed. You should be aware that even though we're talking about systemic steroids, either given orally or IV, actually any route of administration can cause HPA suppression. So you might think that inhaled glucocorticoids or topical or injected glucocorticoids into the joint or the spinal space might not be at high risk, but potentially at very high doses they could lead to adrenal insufficiency. But this is not very common. It's more common in children than in adults. Some inhaled steroids like fluticasone may be a higher risk. But if you use high-potency topical steroids, you can cause some HPA axis suppression. So we should consider evaluation, or at least consider the risk for HPA suppression in patients who meet any of these criteria. With these doses of fluticasone or other inhaled glucocorticoids, patients using high-potency topical corticosteroids, or who have had more than 3 glucocorticoid injections in the past 3 months. Again, any patient who is Cushingoid in appearance or who has signs or symptoms of adrenal insufficiency should probably be considered at risk for HPA suppression. So once again, stress dose steroids are given to prevent acute adrenal insufficiency in the setting of stress. And the thing we need to think about is what's the magnitude of the surgical stress that the patient will be under. Usually we give them hydrocortisone. Other steroids bind to cortisol-binding globulin poorly, and this results in more free physiologically active corticosteroid and more potency at any given dose. And different steroids vary a lot in their anti-inflammatory and their mineralocorticoid potency. And we'll talk about that more in just a couple slides. So here's an example of how I like to approach stress dose steroids. And you'll see a lot of different versions of this kind of approach. So the first question I ask myself is, how stressful is the surgery? Is it minor, like a colonoscopy or maybe an inguinal hernia? Is it major, like cardiac surgery or an esophagectomy? Or is it moderate, like a hysterectomy or a joint replacement? And I'll use this information in the setting of what's the patient risk? Is this a low-risk patient? Is it a high-risk patient or an intermediate-risk patient? At this point, I'm talking about their exposure to steroids prior to coming to the operating room. So if I have a patient who I think is at pretty high risk for adrenal insufficiency, but they're having a minor surgery, I might just choose to not give them any steroids because the risk is so low. I'm not going to give them steroids just for going to the dentist. I probably am not going to give them steroids for these kinds of procedures either. On the other hand, for a major stress surgery, I'll probably give them a bolus of 100 to 150 milligrams of hydrocortisone, and then continue a taper for a few days. This suggests giving 50 milligrams 3 times a day for a day, then 50 milligrams 2 times a day for a day, and then continuing the taper from there. A moderate surgery would have something in between, with a smaller bolus and perhaps a shorter taper. All of this is given in addition to the patient's normal daily dose of steroid, whatever prednisone they're taking at home. This is on top of their normal daily dose. This patient here, who's having a very minor procedure, I wouldn't give them any hydrocortisone, but I would still make sure they took their daily steroid dose. Patients who take steroids will have a series of different side effects that you can observe. The mineralocorticoid effect, think about aldosterone. So these drugs will act like aldosterone, causing them to save sodium and pee potassium, and so they will have a hypokalemic metabolic alkalosis. As a result, they'll have edema, weight gain, and hypertension. Patients who take steroids also will have hyperglycemia and may have some common physical signs, including the buffalo hump, the round moon facies, the red abdominal striae, and very, very thin tissue paper skin. Steroids also cause osteoporosis, peptic ulcer disease, CN effects like psychosis, depression, cataracts, and they are immunosuppressive, which means they increase risk for bacterial and fungal infection. This is a chart I like very much. First of all, because it's sometimes hard to remember the brand name and generic names of all of these different drugs. And it also shows the equivalent dose. So we see a patient who's taking 5 milligrams a day of prednisone is about the equivalent of 20 milligrams a day of hydrocortisone, which is the same as only 0.75 milligrams of Decadron. And so when we give a patient 4 milligrams of Decadron, you can see how this equals quite a large dose of hydrocortisone. This last column shows sodium retention. This is sort of like the mineralocorticoid effect. So we can see cortisol as the standard. We see our other glucocorticoids, which have less sodium effect, and fludrocortisone, which is primarily a mineralocorticoid, having a very big sodium effect. Which patients get steroids? Patients who have asthma or COPD are often given steroids in various forms. Inhaled steroids are very common because they do have less systemic effects. These include things like Asmacort, Flovent, Beclovent, Pulmicort, Advair. As I said, they have a local effect in the lungs and less systemic absorption. They can be depositive in the pharynx and lead to dysphonia or even fungal overgrowth like candidiasis. Sometimes patients do require parenteral steroids given IV, and these are usually in the cases of severe acute exacerbations of the disease. Textbooks have described giving 1 to 2 milligrams per kilogram of IV cortisol 1 to 2 hours before anesthesia, but I can't say I've ever done that myself. Steroids can be very effective antiemetic drugs. Most of you have probably given dexamethasone 4 milligrams IV. There is some data to support giving more, and at one point I was teaching that you should never give more if all you're doing is treating nausea, but it does seem that 6 or even 8 milligrams may have some additional benefit. Usually it should be given near the beginning of surgery, and I give it with induction of anesthesia. It may prevent surgery-induced inflammation, as well as increasing release of endorphins. Dexamethasone is about as effective as ondansetron or droperidol. And in diabetics, you want to think about the risks of hyperglycemia versus the benefits of your antiemetic therapy. And in a severe diabetic, you may want to consider your other options. Dexamethasone in particular is often used in the treatment of cerebral edema, usually at larger doses, like 10 to 20 milligrams IV, and it's effective for treatment of elevated intracranial pressure in cases of global ischemic injury or head trauma. We use dexamethasone a lot in the operating room during brain surgery because it decreases the cerebral volume, which allows the surgeons to get better exposure and retraction of the brain. As we said before, steroids are anti-inflammatory, and many patients who are on steroids are using them for this purpose. Anti-inflammatory benefits include treatment of postoperative pain, lumbar disc disease, collagen diseases, arthritis, skin disorders, ulcerative colitis, acute spinal cord injury. And we may take advantage of the anti-inflammatory effects in the case of post-intubation laryngeal edema. So often a patient who has a difficult airway or lots of instrumentation of their airway will be given 0.1 to 0.2 milligrams per kilogram of IV dexamethasone to try and limit airway swelling. A few more indications for steroids include immunosuppression. So patients who get transplants often will be given steroids to decrease their risk of rejection. Patients who have respiratory distress syndrome often get steroids, as well as treatment of certain cancers like leukemia and patients with myasthenia gravis. All of these patients on this slide and some of the previous slides should be evaluated for any past or current steroid use, and that should be part of your preoperative assessment. When you see a patient who has some of these things, you may want to ask if they have been exposed to steroids in the past year. That's it for our discussion of steroids. Please let me know if you have any questions about any of the material, and we'll continue again in the next video.